I'm the wellness nurse for the County of Wayne. I like to bring awareness to colorectal cancer. According to American Cancer Society, colorectal cancer is the third commonly diagnosed cancer, with the second leading death of cancer-related. This year alone, according to the Colorectal Cancer Alliance, 95,000 people will be diagnosed with colon cancer, with over 39,000 of it being rectal. Sadly enough, 50,000 of them will die this year from colorectal cancer. I've invited someone who's dedicated his career in treating gastroenterology and hepatology, which is liver disease, along with hepatitis, pancreatic disease, acid reflux, or better known as GERD, and inflammatory disease. But more importantly, he does colorectal screenings. Dr. Futch, welcome to our segment on talking about colon rectal cancer.
Thank you, Michelle.
So tell us a little bit about your education, where you're from.
Well, actually, it was born in North Carolina, and then soon after, both my parents, who were from this area, moved to Richmond, Virginia, where I pretty much grew up. Attended the University of Richmond, and then got a master's degree in microbiology and immunology from Virginia Commonwealth University before I went to med school in Norfolk, Virginia, at the Eastern Virginia School of Medicine. Stayed there, did my residency, and then later did my fellowship back in Richmond at the Medical College of Virginia in gastroenterology and hepatology. And I finished that in 1996 and moved back to North Carolina. I've been in practice here ever since.
So you like North Carolina better?
It's a beautiful state.
Dr. Futch also serves as former chairman of the Department of Medicine and the chair of an endoscopic committee. He is a part of the Wayne UNC healthcare systems here, where he practices in his clinic. Tell us a little bit more about your clinic.
Well, recently Wayne Physicians was taken over, and we're now part of University of North Carolina Physicians Network. And I've been here in Wayne County now for almost 10 years, and I've been practicing gastroenterology since that time. All my procedures are done at Wayne Memorial, or UNC Wayne, and then I have a clinic. My office is just across the street, and see patients there Monday through Friday.
Monday through Friday. You're also the assistant professor at Campbell University.
I am.
As well.
I teach predominantly fourth-year medical students, but some third years rotate through my gastroenterology clinic and learn a little bit about the importance of colorectal cancer screening, and we do a lot of hepatology and liver disease. And they'll usually spend about 4 weeks on their rotations with me throughout the year.
That's nice. That's nice. It's great that we're starting to expand with that. What I came across you when I found your article that you had posted on LinkedIn. It said, new study reveals nearly 40% of young adults with polyps on colonoscopies. They have a higher risk of polyps.
Yeah, that was a recent study that's just changed the recommendations of the American Cancer Society on the age at which patients should undergo colorectal screening. Prior to this article, we've always recommended that patients begin colorectal cancer screening at age 50 or perhaps a decade earlier if they have a family history of colon cancer. And about 33% of adults at age 50 will have an adenomatous or precancerous polyp. By the time patients are getting age 70, about half of them will have a precancerous polyp. Based on this study, the recommendations have been to encourage patients to begin colorectal cancer screening at age 45 instead of age 50. And this is along the lines of what our current recommendations are for Afro-Americans also, is that they also seek colorectal cancer screening a little bit earlier, just because of a higher incidence of colorectal cancer deaths in the Afro-American population. So,
So what do you think some of the risk factors are for that age group? Is it their lifestyle? Is it that they're not moving much?
I think the risk factors are the same for the younger patients, except we're becoming a society of inactive people. We're eating a lot of fast food. We're having a high fat diet. We're gaining weight and reaching higher BMIs at earlier ages. Obesity's very common in children now, and subsequently it puts us at risk of cancers at an earlier age. Obese patients, smokers, patients on high-fat diets all are at higher risk of adenomatous polyps and subsequently higher risk for colon cancer.
Sadly enough, our society is so busy that fast foods is always a convenience, but not in the long run.
Right, and fresh fruits and vegetables are a little harder to come by.
True.
And a little more expensive, so patients have a tendency to have a higher fat diet.
Right.
And it's just kind of society and our social, what we learned growing up, and our taste buds get educated at a very early age, and it's hard to change those things.
When we celebrate, what do? Let's feast.
Exactly.
Let's talk about a little bit about colorectal cancer and its location.
Well, obviously, colorectal cancer, refers to the colon. My location, in years past, about a third of colon cancers are found in the very distal colon, meaning on the left side or closer to the rectum. And over the years, the incidence of colon cancer has actually increased in the right colon, or at the very beginning of the colon. So early on, we did a procedure called flexible sigmoidoscopy to look for screening for colon polyps and cancer. And over the years, we've started encouraging colonoscopy. Colonoscopy allows you to view the entire length of the colon, which is kind of what the recommendations are now. Most colon cancer screening tests either looking completely at the colon or don't allow you to actually find polyps and remove them. And so subsequently, we recommend that you do some of these alternative tests every 5 years. If you have a normal colon cancer if you have a normal colonoscopy at baseline, then the recommendations are, unless you have a high risk, that you only have to do them every 10 years. So
that's a good amount of time.
A normal colonoscopy at age 45 or age 50 would mean that you wouldn't have to have another one until you're 55 or 60 years old. So it's a pretty reasonable test to do. And I tell a lot of my patients, if I was going to pick one particular test that was going to help me reassure myself that I wasn't going to get cancer of any type, if I had to pick one test, it would be a colonoscopy, just because it's the number 2 cause of death in the United States from cancer. And it's one of the few cancers that if you remove these little precancerous polyps, that you can decrease your risk of getting colon cancer about 80%. So it's a very worthwhile test to do. It's not always convenient, and some people are a little intimidated, and some people hear bad things about the preparation, getting ready for colonoscopy.
Right.
But I think in the long run, it's all worthwhile. And most people, after they've done it the first time, they realize it's not as big a deal as they had made up in their mind.
That's me.
Yeah.
That's me. It was actually one of the best sleeps time I've ever had. I slept very well. So let's talk about a little bit about who can get colorectal cancer. Is it mainly for women, or is it more men, or is it?
The risks in the sexes, men and women, are pretty equal. At baseline, on your initial colonoscopy, about 1 out of 5 women, or 20%, will have an adenomatous polyp, and about 1 out of 4 men, 25%. So it's pretty comparable. And then that incidence, as I mentioned earlier, increases from age 50 to age 70, so that these polyps become more common, and the incidence of colon cancer also goes up with age. So.
We have risk factors that are associated, as we talked about before, with sedentary lifestyle, decreased activity. What are some of the risk factors that we didn't talk about earlier?
Obesity, high-fat diet, smoking. Smoking pretty much increases the risk for all gastrointestinal cancers and a lot of other cancers as well. Most people just think of smoking and lung cancer, but
it goes along with a lot of health diseases.
All those, high-fat, low-fiber diet, all those things contribute.
I think I read somewhere where, if you have a relative that has been diagnosed with colon polyps or cancer, it increases your risk.
That's generally a first-degree relative, unless you have several relatives across a couple generations. There's a couple hereditary conditions, familial adenomatous polyposis syndrome, and there's a non-polyposis syndrome as well, that increases your risk if you have family members that have had that. So in those particular patients, if they have that family history, recommend that you start colonoscopies at around age 40 or 45. And that may even move to a younger age. Now they're recommending screening beginning at age 45. So
if you have a known family relative that's already been diagnosed, please encourage your other loved ones to have it done. And some of the things I've heard about colorectal cancer is it's almost silent. You don't know that you have an issue because some of the symptoms with nausea, bloating can be referred to something else, minor.
Yeah, I go through this with patients quite often, particularly patients that are a little resistant to the idea of colonoscopy. They'll say, well, I feel fine, I don't have any change in my bowels, I haven't seen any blood, why do I need to have a colonoscopy? And I mean, it goes back to what I stated, that 1 out of 4 men and 1 out of 5 women have an adenomatous or precancerous polyp and don't even know about it. And you don't want to wait until you become symptomatic. If you're starting to have change in your bowels, you've got a big problem. If it's related to a cancer in your colon, if you're waiting till you see blood, you may never see blood until you have distant metastasis, because the blood can very often get mixed in with stool and not even change the color of your stool. So if you're trying to visually see, and I have patients that tell me, well, it's just bright red blood, so it's probably hemorrhoids, and I always tell them that that's a very big mistake, especially if you're over 40 and are seeing blood, to assume that it's hemorrhoids. So all those are things that you should discuss with your physician and determine your risk factors. And really, if you haven't had a colonoscopy and you are having any of those symptoms, you may want to go ahead and have a colonoscopy.
Sure. So some of the symptoms you can just associate it with something else, but of course, if you see blood in your stool, that's a big key factor. You need to get that checked out and not wait and see if it's going to stop.
Absolutely.
Okay. So when we test somebody for or do a screening, what does it involve? We talked a little bit about colonoscopies earlier, but there's also, I've heard or read, colonoscopies with CT or virtual. So tell me a little bit about virtual colonoscopies.
Yeah, virtual colonoscopy is usually done by CT scan. The advantage is that you don't have to have a colonoscopy, which I'm not sure is much of an advantage. It may have a little bit less risk than a colonoscopy, but only 1 out of 2,000 people have a problem with a colonoscopy. So the risks and complication rate is very low. There are risks to CT scan too. There is a small perforation rate even with CAT scan. And you have to worry about the radiation exposure. I mean, several CAT scans can increase your risk of some other types of cancer just from the exposure from the radiation. So the other thing is that they recommend you do those every 5 years. They're really not for patients that are in high risk categories. Like if your mom had colon cancer, you wouldn't want to have a virtual colonoscopy or a CT scan. You'd probably want to go ahead and have a colonoscopy. The other thing is if they see something on a CAT scan, and it may be a polyp, or it may be some stool that didn't get cleaned out, you're going to have a colonoscopy. Which brings me to the other, some people think, oh, if I do a CT scan, I don't have to drink that laxative and get my bowels cleaned out for colonoscopy. Well, that's not true. You have to get cleaned out for virtual colonoscopy as well. And finally, if you see something on a CT scan, you can't remove it. You have to get referred to a gastroenterologist, have a colonoscopy. And if you're having a colonoscopy, it's kind of one-stop shopping, really, because if I see a polyp, a precancerous polyp, I can remove it at the time of your colonoscopy, and you've only had one procedure. You haven't had to drink a laxative twice, once for a CAT scan, once for a colonoscopy. So
right.
I mean, there are instances where that might be a legitimate option over a colonoscopy, but most people in my specialty probably would agree that that is not ready for prime time yet.
Well, I can understand now that you've clarified that with me. So tell me, what's the procedure of getting this done? So in your office per se, they call and make an appointment? And
I mean, we approach it two ways. Colonoscopies have become so common nowadays that patients that are high risk or have special needs, they've got complicating medical conditions such as heart or lung problems that we need to evaluate them in advance. We need to consider stopping blood thinners. I usually will always have those patients come in and talk to me in the office, and then we weigh the risks and benefits of colonoscopy, because they may be a little higher risk than that 1 in 2,000 risk of an average patient.
Right.
Other patients, because everybody's busy nowadays, and to go to the doctor and have them talk to you about colonoscopy and sit there for an hour in his office and then come back and then go to have your tests another day and sit for another couple hours. In our busy society, most people don't have the time or really want to sit and do that. A lot of the referring doctors now, we have what we call a fast track, where somebody who is having a screening test that doesn't have a lot of medical problems, their doctors will send their records to us. My office staff will contact them, let them know that their doctor wants them to have a screening colonoscopy, and then they'll come by the office, go over the instructions for the bowel prep and to get ready for a procedure with my nurse, and then they just show over to the endoscopy unit at Wayne Memorial one morning, and I'll introduce myself, explain the procedure to them, answer any questions that they may have, and then anesthesiologists will evaluate them real quickly, and then we'll bring them back to the procedure room, and they're usually in and out of them within about an hour and a half, and we'll remove polyps. If we do remove polyps or do biopsies, I'll have those evaluated by a pathologist, and the report will be sent to my office, and I'll usually have the patients follow up with me at that time to go over the results, because usually that will generate a lot of questions, particularly as to what is my risk in the future, how often should I have colonoscopies now that I've had polyps, and those are things that are easier for me to sit down and talk to them face to face about. If they have a normal colonoscopy and it was a screening, I'll send a note to their family doctor. I'll see you in 10 years. I may not look the same, but I'll be here.
Yes, right.
10 years
Unfortunately,
older.
we have a chance.
But for those patients, and unless they have change in their symptoms or new concerns, they really shouldn't need to have another colonoscopy for 10 years.
That's a long time.
You get a lot of mileage out of a normal screening colonoscopy.
And it could save your life. Dr. Futch, thank you for joining us today on colorectal cancer awareness.
Sure.
And
thank you for having me.
Thank you, and letting us know we can have our colonoscopy every 10 years if it goes well. And like you said, a lot of bang for your, I wouldn't say buck, because I didn't want to go there. I didn't want to say there.
You get a lot of mileage from the time you put into it.
Thank you.
Yeah, it's like a lot of other screening procedures, that have to be done once a year, mammograms and pap smears and prostate checks for men, which are done yearly. This is, if you have a normal exam at baseline, you only have to do them every 10 years. And again, it's one of the few screening tests where we can actually intervene in the natural history of a cancer by removing precancerous polyps, completely remove them, and decrease your risk of cancer. Where majority of cancer screening tests, for instance, mammograms, usually if they find something, it's a cancer, and something more invasive needs to be done. So this is one of the few cancer screening tests where you can actually intervene before cancer and then change the whole natural course and prevent people from developing cancer.
Wow.
Which is why the recent studies have shown that there's been a dramatic decrease in the incidence of colon cancer in the United States, because colonoscopy is becoming finally more and more accepted. We're still trying to get, our goal is to try and get about 80% of the U.S. population to get colon cancer screening around age 45 or age 50, and we haven't quite reached that number yet, but we're getting there.
Making awareness like this really helps get it out. So give up an hour and a half of your life for every 10 years is worth it.
Absolutely.
Worth it.
Absolutely.
Well, thank you.